Hey guys, we're going to be looking at a study that combines dry needling with exercise compared to just exercise for management of patellofemoral pain. In the introduction, they talk about how there has been demonstrated weaknesses in core muscles and affected core muscle function in patients that have patellofemoral pain, including the quadratus lumborum and the glute medius. There has been a higher prevalence of trigger points also in the glute medius and the quadratus lumborum in patients that have patellofemoral pain. There's been evidence that these trigger points will lead to altered muscle strength, function, activation patterns, and motor control. In unilateral patellofemoral pain, the ipsilateral glute medius and the contralateral quadratus lumborum provide this frontal stability and prevent hip adduction, which if your hip is adducting, that's that valgus force is going to apply a lot more force on the patellofemoral joint. So the purpose of this study was to determine if using just exercise compared to exercise in combination with dry needling of the ipsilateral glute med and the contralateral QL would have a difference in results. Looking at the interventions, both groups had 2 sessions per week of exercise therapy, along with 3 days per week of a home exercise program. They did this for 4 weeks. In combination, one of the groups also had in combination dry needling of, again, the ipsilateral glute medius and the contralateral QL. They use good sized needles for this as well. They could use a little bit bigger ones for the glute, but in the glute they used 50 millimeter needles, in the QL 100 millimeter needles. So you know that they're actually able to get down to the muscle. Now with the QL, we talk about more so of targeting the QL versus actually hitting the QL. The only way you know for sure that you got the QL is under ultrasound, especially with how thin of a muscle it is. But in this study, they're trying to needle down towards the transverse process, which that's where the QL attaches. So you can be pretty confident that you're at least affecting that muscle. You should be getting really, really close to it. As for needling protocols, how they actually did it, it's all the way down at the bottom where it actually shows how they needled. So for the QL, they did this in a sideline position. They palpated for the transverse process, and then they targeted going right down towards that transverse process. They also stayed lower than L2, so they were trying to basically needle L3, L4. That's really our safest way of doing this, staying away from the lung field, and also really L3 is the only one that's exposed because the second lumbar vertebrae is covered by the 12th rib, the 4th lumbar vertebrae is covered by the iliac crest. So really L3 is kind of like the best shot we have at QL in that sideline position. As for the glute medius, they also did this in a sideline position. They went between the greater trochanter and the iliac crest. They went just anterior to that, and then they went anterior to the tensor fasciae latae, rolling their thumb over it as they're looking for these trigger points. All of these, they did trigger point dry needling. None of this was based off of acupoints. They're feeling to find where that tender spot was in a taut band of muscle, and then they throw a needle in that. They also, just so you guys know, they could have done a better technique. They did fast in, fast out approach, going back into the same spot. See, up and down. Right there, it says that they moved the needle up and down with no rotation. They also did not use any electrical stimulation. So just take this study with a grain of salt, knowing that they could have had better needling technique had they rotated the needle, had they changed the angle, especially when you're in the glute end. You can go in any direction as you're in the glute because you have a backboard with the ilium. And then they also could use electricity with this, and that would have made the results better. Going back up to their interventions. Okay, participants were able to take NSAIDs. This is in either group. However, before they had their measurement of the outcomes, they had to stop taking NSAIDs at least 48 hours beforehand. Needle sessions were a little bit longer than the group that did not have needling done. So between 15 and 40 minutes was how long the sessions were. But the group that had needling done, it was an extra 2 to 5 minutes. That's because they just went in, did some pistoning, and got out. They did not have those needles left in situ. As for their outcomes, they were checking this at baseline, 4 weeks, and at 6 weeks. Again, they only treated them. They only did these exercises for 4 weeks. So they measured their outcomes 2 weeks after they stopped the treatment. The therapist who did their outcomes, who was doing their therapy, for their exercises, they did not know. They were blinded to what treatment the patients received. primary outcome was knee pain. Secondary outcomes was pain pressure threshold for the trigger points in the glute med and in the QL. They also did a step-down test and a modified star exertion balance test. I'll show you guys what those look like. And then they also had a outcome measure called the Kujala. This was done it's a Persian version because this is a study that was done in Iran. But this was used to evaluate the objective and subjective functional performance. So subjectively, they use a questionnaire, that Kujala questionnaire. Objectively, they use the step-down test and the modified star exertion balance test. For that modified star exertion balance test, this was done standing on their effective leg. They reached in all three directions, anterior, posterior medial, and posterior lateral, with their other leg touching their toes as far away as possible and then returning to their standing position. They also had this normalized based off of the length of their lower extremity. And then for the step-down test, this was done, they were standing on a 20 centimeter step, and they had their patient come down, touch the ground with their opposite leg, and then come back up onto the step. And they did this as many times as they could within 30 seconds. As for pain pressure threshold, they used a digital algometer in order to apply pressure onto the trigger point, see how much pressure until they really felt that pain. So it's a pain pressure threshold. The higher the pain pressure threshold, the less sensitive they are to pain. All right, sample size, we'll get into it. They had 40 participants total. So 20 participants per group. They randomized these. There's our statistical analysis. As for the results, we'll go into the area where I have it highlighted actually. So comparison of the baseline versus week 4, there was improvements in pain in the subjective questionnaire, that Kujala questionnaire, their step-down performance, and their star exertion balance test. All of those improved in both groups. In the group that had needling done, they had better outcomes. So you guys can see from baseline to week 4, there was great improvements in the exercise plus the dry needling group. For all of these, for pain, for their Kujala score, for the step-down test, for pain pressure threshold, and for the modified star exertion balance test. These comparisons were also better at 6 weeks for the dry needling and the exercise group, and they saw changes between 4 weeks and 6 weeks. So they continued to improve in the group that had dry needling done. That was not the case in only the exercise group. So having needling in combination with exercise had better outcomes. You guys can see a graph for all of these. So here's that Kujala score. Again, this is a subjective questionnaire. You can see it improving, and it was statistically significant. Same thing with the step-down test, statistically significant. Same thing with pain pressure threshold for the QL and for the glute med. All of these statistically significant. You guys can see their p-value right there. Modified star excursion balance test. This is anterior, posterolateral, posterior medial. All these had improvements. And then same thing with their pain. Look at how much of a dip this is in pain if they had needling done. Look at all these. Like the blue line for all of these, the blue line is the needling group. The dotted orange line, this is all just a straight up exercise group. You guys can see how much better it's improving if they had needling done. By the way, you would expect that with the pain pressure threshold over the QL and glute med if they were putting needles in the trigger point itself. But looking at pain at the actual patellofemoral joint, look at how much that improved if they had needling done in combination with exercise. So the reason this is a really cool study is because a lot of people will say that they don't need to use needles because they're getting good outcomes, right? And you would get good outcomes. These patients are still improving if they had exercise done, but you're getting even better outcomes if you just utilize needles. So patients are going to get superior outcomes from doing the same exercises you would have done either way in combination with needling. Why would you not utilize that intervention if you're going to get better outcomes for your patient? I can guarantee you that patients are going to want you to utilize this treatment if they're going to get better outcomes. Looking at the discussion. So the results demonstrated that both treatment protocols led to statistically significant improvements in pain, function, and pain pressure threshold after treatment and at 6 weeks post follow-up. So that's at 4 weeks and at 6 weeks. However, in the group that had exercise only, their improvements in pain, their subjective outcome measure for function, and their modified star excursion balance test. These were clinically significant. Comparisons between the two groups showed that the combination of exercise therapy and dry needling had significant added benefit in all the outcomes. These are the actual measures for all their tests. So this is their pain, Kujala score, step down test, pain pressure threshold. You guys get it. So this is the actual table looking at all of it. The results of their study support their hypothesis that combining dry needling for the glute medius and the QL with exercises had superior beneficial effects over exercise group for pain, function, pain pressure threshold in female athletes with patellofemoral pain. Although QL and glute medius pain pressure threshold showed statistically significant increases in both groups, the changes were clinically relevant only in the dry needling group. In line with previous results, that showed that adding dry needling to the quadriceps for patients with patellofemoral pain led to earlier or greater improvements in pain and function. So there's other studies that showed that needling the quads had improvements in pain. This one is needling the glutes and the QL had improvements in pain. Why not throw needles in all of those muscles? So in addition to the possible biomechanical effects of treating trigger points in the QL and glute med, because those control frontal plane stability, and if you throw needles in that, that's going to improve their movement, that biomechanical effect in pain. They also say that there's a central neurophysiological effect in dry needling that may have contributed to the results. The reason for that is dry needling can release analgesic substances into the bloodstream and the cerebral spinal fluid by stimulating A delta fibers. This in turn may cause a pain relief in remote areas other than the site of treatment. So this mechanism could also account for some of the reason for why they're having pain relief. So there's a biomechanical effect by treating the muscles that control frontal plane stability, along with the neurophysiological effect of providing an A delta fiber stimulation that is going to reduce the pain. That is going to create more of an opioid response in the body, and that can happen distal to the site of where you are needling. All right, so the results of the study are in line with recent consensus statement of patellofemoral pain management, which recommends combined knee and proximal focused exercise therapy. In addition, our main findings suggest that targeting trigger points in proximal muscles relative to the affected knee is a potentially effective adjunct treatment for unilateral patellofemoral pain. Study limitations: they did not have any men in the study; it was only female athletes. Secondly, there was no placebo group. Thirdly, home exercise program was unsupervised. And fourth, the exercise protocol was limited to 4 weeks, so really should have been going on for a bit longer. That was not aligned with the best practice recommendation. Finally, our follow-up was limited to 6 weeks after the start of treatment, so there may have been different results had they looked at this a little bit further out than 6 weeks. Conclusion of the study: dry needling of trigger points in the ipsilateral glute medius and contralateral QL combined with exercise therapy can improve pain, function, and dynamic balance more than exercise therapy alone. Therefore, adding glute medius and quadratus lumborum dry needling to exercise therapy may be advisable to enhance the effects of unilateral patellofemoral pain rehabilitation. Really easy to do. Just throw some needles where it hurts in the glutes. QL, make sure you have good training if you're needling the QL, because that one can be a little bit more dicey. But glute medius, really, really easy to needle this for patients that have patellofemoral pain. If you guys have any questions on this study, how to do this needling, just reach out.